Okay, so you bought the practice right before COVID hit too. Got it. Got it. Or right at that time. Got it.
Correct. Correct.
Okay. Um, what was kind of one of the main driving forces to contract with some of those lease networks?
I had absolutely no idea that I
Okay.
was being, I didn't know the system. Let's put it that
Yeah.
way. And so the person helping me with my credentialing gave me a list of all the main carriers, the ones I
Mhm.
named and some others.
Yeah.
And so the impression I got was these are the main dental carriers that I will be participating with as a network
Mhm.
provider. There was no information given to me by either party, whether it was the person helping me credential or the plans themselves that about network leasing at all. So that was an accidental involvement.
Got it. And then I also had a member that very early on when I started with CDA, she was just starting out, starting a brand new practice, similar to yours. I know you purchased the practice, but she was contacted by someone that they told her that she was only going to be in network with these 5 plans. Well, she sent me the list, and once I explained to her, it's actually like 36 plans that you're going to be in network with. She had no experienced biller. She had none of that to back her up. And so it was a huge eye-opening for her to find out
Mhm.
about the lease networks. And it sounds like that's kind of the same route that you went down, right?
Yes, and I think, and again, this might be something that you find as you talk to different providers, dentists with different setups in their offices. So one thing is I don't have an office manager, so I am the office manager. But when the EOBs can't come in, I'm in charge of depositing checks. Okay, so I get a firsthand view of these EOBs. So as they were coming in, that's when I started to really pay attention to
Yeah.
where is this payment coming from? This is not one of those lists of carriers.
Yeah.
What is this insurance? And once I started doing my own digging,
Mhm.
that's when I found out about that
The
this
lease networks. Yeah.
octopus-like tentacles that these carriers have with
Yeah.
these. And the more I started reading about it, the more I understood. So I was paying attention to what was coming in the door as far as
Yeah.
where it was coming from. And looking at those EOBs gave me clues.
You have a rare opportunity that you saw those EOBs coming in firsthand, where a lot of the offices that we talk to, the dentists don't even see those EOBs, and the office manager or whoever the biller is just processing those and taking the discount, not knowing that potentially this is something that they could get out of a discount with, right?
Right.
So at this point, you're starting the process of trying to go out of network with some of those leases. Are you going to keep some of them?
So, and just a hats off to CDA. The practice support guidelines on lease networks and getting out of networks has been
Yeah.
an invaluable help to me. I used it
The resource,
really
okay, and part of
thoroughly.
the evaluating dental, yeah, part of
Yeah, I
okay,
mean, I had
yeah,
highlights, I had a
checklists,
checklist. I was going by that structured. I
fantastic.
like lists, so that really
Yes.
helped me. And it
Yeah.
helped me organize, the timelines
Hmm.
and gave me clues on what I should, because I'm doing this by myself. So
Yeah.
it was nice to have that support. I wasn't paying a company to do this for me. I was taking it on myself. So hats off to that, all the effort that was put into that really helped me a lot. So thank
Good.
you.
Yeah, it's nice to hear that. I appreciate that. Yeah, we put a lot of time and effort into resources and making sure that we're putting the right resources out there that are valuable to members. And there are some times where, Miguel, you can confirm this, we get reports all the time of what resources are utilized and what resources aren't. And there's times where we go through the list and they want to kind of retire some of them. And Miguel and I are like, like,
Yeah,
Not
that
that
one,
one.
that one was
yeah,
invaluable. That one
yeah.
was perfect. It was wonderful. Yeah, for me. Again, everything was very organized, very structured. And then I thought I was okay. Um,
You're
and
like, done, done, done. Yeah.
then, and then again, like I said, I'm getting EOBs and and suddenly, I'm starting to hear from my gal Elena, that oh, lo and behold, we're in network, and I cannot tell you how much of a confusion this trickled down to the patient part
Yeah.
of things.
Let's
And
talk about that a little bit. Yeah.
yeah, that really it actually cost me patience.
Oh,
Not too many, thankfully, but that inability to really be very open and transparent with them
mhm.
made it look as though we didn't know what we were doing. And it
Yeah.
reflected very negatively on me um,
Mhm.
because I cannot give them an accurate, estimate because I'm not told what our fee schedule is. And so everything is
Mhm.
very opaque. And the administrative time taken to actually chase down, what is our patient liable for as far as a copay? What is our fee schedule? What is the structure we're going off of? Having those basic answers, I mean, it's just incredibly frustrating, time consuming, and then again, at the end, reflects on us badly.
Yeah. Yeah. Yeah.
And
There's so
so
many
I took
reasons.
the time, just like the practice support guideline said, to send out letters to inform them that, we'll be getting out of network. And I did that whole song and dance. And then
Yeah.
at the end, to come to find out that, oh no, just kidding, we're still in
Yeah.
network. That part was just so demoralizing, actually. Yeah.
Because you took all the time, you did the right steps, but then all of a sudden you still got swept in under
Right.
into the tidal wave of it. Yeah.
Right,
Yeah.
right. Um, I have a very recent example of a company and then their leased network not working together anymore. I guess this decision was made early in this year, and we received no notice of this. Nothing, not a single piece of mail, no emailing, no notification that this happened. And
Uh-huh.
the patient you had all her diagnostic and imaging done in July, and the claims were quote stuck between these two parties. One
Yeah.
saying I can't do anything, the other one saying, well, the other one should do it, and this one, back and forth. Meanwhile, the claims are stuck and going nowhere.
Hmm.
We don't get paid. The patient doesn't know what's going on,
Frustrating. Yeah.
and she has treatment. She has treatment to be done and can't schedule. So
Mm.
that's July. We finally got some answers back 2 weeks ago. That's
Oh,
end of
wow.
October. So
Goodness. Okay.
patients are right, that they're
Yeah.
taking the brunt of this, and we don't get notified. That is my
Yeah.
frustration. And again, I wish I could tell you how many chart notes are in that patient's chart with my front office person being on the phone, chasing down supervisors, trying to get answers, being given HR department numbers when they don't work.
Yeah.
All that number, one person saying one thing, the other one conflicting that information, and
Mhm.
round we go. And
Yeah.
the patient just wondering, when am I going to get treated? How much is my copay? And do we
And
trust pre-authorizations at all at this point? The repercussion is costly.
oh, for sure, especially the patients. Yeah.
Right,
Yeah.
right,
When you're looking at a patient and they're asking you what their copayment is, and you say, I don't know. And what does the plan cover? And you say, I don't know.
right.
That doesn't put a lot of confidence in that patient that
No,
you know what's
no.
going on. Yeah.
Right. It's such a it was such a fiasco, and pre-authorizations are not reliable in that same breath, because
Yeah.
we can't even get a past claim resolved. How are we going to rely and depend on a pre-authorization? So again, patients are stuck. They can't
Yeah.
book, they can't budget, and I don't even need to go into how tight everyone is these days. And they're
Sure. Yeah.
trying to budget and trying to put their healthcare and dental care in buckets, and they can't because
Yeah.
this network can't give us straight answers.
So when you talk to your patients now about what plans you are in network, do you specifically go over in network, out of network, or do you just say we can accept your plan, or how do you communicate with them of who you're in network and who you're not in network with?
Yeah. So as far as for example, new patients, or is that
Mhm.
mostly what you're?
Yes, yeah.
Yeah. Yes, we do. And we've sort of perfected our script in that if somebody calls and and yeah, we're out of network with that plan, we tell them. We tell them quite directly, but we also say, having said that, now that we know how intertwined things can be in the back end, Elena does mention that she's going to look into their specific plan for them, and that she'd be happy to, look at what type of policy it is, and then reach back out to them on the nuances and the coverages and so on. So
And if we
like
see.
that, because it's sort of a maybe not in network, but possibly, and then that leaves the door open, and it doesn't kind of shut out a patient, from the beginning. And then it gives us an opportunity to see exactly what we're looking at and whether or not we are in network or not.
Yeah,
And then what fee schedule that particular plan would be following.
you might have touched on this a little bit earlier. It's hard to figure out what fee schedule you're going to be paid by, right?
So one particular phone call, um, where we were asking that exact question, came back with the answer from the customer service representative. The answer was the fee schedule that starts with a C.
We hear a lot of times where members will call to get fee schedules from the plans, and if they're an out of network, or the representative doesn't know that they're in network through a leased network, they'll tell them it's proprietary information, we can't give it to
Right,
you.
that too.
And so
That too.
the treatment
That's
coordinators are really going in blind and having no
correct.
idea
Correct.
what to tell the patient,
Correct.
what potentially their out of pocket is going to be for some of
Exactly. And
these
that's where
services.
right, exactly. And I think and I don't think, and I'm sure, Lisa, you can attest to this, but patients don't, they find that so surprising. They find it so unbelievable almost that we don't know.
Yeah,
You know,
yeah,
why can't you
but
tell me how much my night guard is going to cost? I mean, you did this all day long, you
yes,
should know. So that's why we tell patients that we may be out of network, but we'll look into your plan and we'll see, more details that way. And we'll be able
mhm.
to give you more detailed information. And then, as far as copays and coverages and percentages and so on and so forth.
When you were going out of network and starting to kind of chop down some of those lease networks, I know you said that you did lose some patients, you did have some attrition. Did you track that at all? Was that something you were super concerned about?
Yes, I did. I did a lot of metrics beforehand.
Okay.
I looked at each plan, how many
Hmm.
patients were under that plan. I looked at how many claims that plan we submitted to that plan, and then the
Hmm.
revenue from each one. And then I looked at my own fees, and then I looked at percentages. So I had one column where it was like 80% coverage, and then another 50%, and so on and so that I could see what the patient portion would be.
Hmm.
As far as attrition, I estimated the highest, 50%,
Sure.
so that I could be more conservative. But to answer your question about the attrition tracking, I did track it, and it wasn't all that much, especially because we thought we were out of network, and then we
You
got,
got pulled back
bumped back
again.
in. So those patients that might have been on the cusp of got
Mhm.
a very happy call from us saying, uh,
Guess what?
you're
Yeah.
not going to be paying out of network uh, copays or whatnot. And frankly, even looking at my metrics afterwards, and looking at how many had left because they had no out of network coverage was probably less than 3%.
Oh, that's
And
really good.
that's because, yeah, and that's because of their employers. So that had a big role to play. And that's what I was paying attention to is who
Mhm.
left, and why. And it was mostly those that were on individually bought plans.
Yeah.
Yeah.
One of the questions that we have listed was, have you experienced any delayed payments or rejected claims due to the network rules? And I think you kind of answered that a little bit earlier with definitely with the delayed claims.
Right.
But any other issues where maybe you submitted a claim expecting it to be paid and then come to find out it's something that's inclusive of another procedure and this particular plan isn't going to pay for it. And
Right. Yes, we had huge problems with because it almost seemed like there was no human at the end of the claims
Mm,
process.
yeah,
Because I mean, my documentation is as detailed as it gets. So I know that when we submit a claim, I know what we're submitting. I know how in depth we go as far as what we submit. So when the claim comes back saying we don't have enough information, that's a red flag for me.
yeah. When you started looking at going out of network with some of those lease networks and things like that, I'm sure fee schedules were probably the main reason why is that you were being compensated at such a low fee. But did you try to negotiate with them on any
I
levels to
did.
see if they would increase it? Okay, okay.
Did.
Let me know.
And I did
How
that.
did that go? Okay.
Yeah, yeah. It was okay. But they're limited. They
Yes.
can only do so much. Um, and so yeah, it helped. But at the end of the day, with again, the graph of the expenses rising, versus the change in the reimbursements that they might agree to still
Mhm.
doesn't match up. Conversely, I would get patients who came to me because they left their dentist,
Another instance.
right? And the very first and especially if they started out with, I loved my dentist, they were wonderful and I was seeing them for 10 years and then and this is the key word, is stopped taking my insurance, of course. And I
Yes.
always try to educate them. And I say, if you loved
Yes.
your dentist, I really do think that they are doing this for your benefit. And if you're
Mhm.
able to see them and work with them, I would suggest that you stay with them. And they get very surprised with that answer.
Yes.
um,
Yeah.
it's not one that they're expecting. But yeah, I do get those patients too. And so we try to, educate them on what that means, what going out of network really means.
When did you introduce the discount plan? Your in-house discount plan into the
2022. Yeah,
okay.
22.
And what was the reason behind that?
Because I was preparing to
Mhm.
slowly transition out of some of these
Got
plans.
it. Smart.
And I also looked at the number of patients who didn't have insurance,
Mhm.
who were self-employed or who were retired. And I wanted a third prong, if you will, one
Yes.
more option for them. So that's why I did it. And it's been pretty successful. It's been growing little by little. So I'm happy with
Oh, cool.
how it is an option.
If you could go back, what kind of advice would you give any other dentist in your same situation as
To
far as with the
be
lease networks?
Yeah. So, okay. Yeah. To go in with eyes open, to have as much knowledge as they can.
Mhm.
I would say to not delegate this part and be involved, because at the end of the day, it's their practice and their hard work and their patience. So really to dive in, learn what
Mhm.
these carriers do and don't do, stay organized so that they could, look at, all right, what's the list that's under this carrier? What's the list under this carrier? And then keep an eye on, if they could, maybe, be mindful of the EOBs, look and see who pays very late, Look and see which patients are complaining and why, and then trace that back to that plan. So if there's a disgruntled patient, keep an eye on that and see why. And maybe it may be something they can change themselves, through the provider relationship or something, and then make it right. So I think being hands-on a little bit and not being so blind to what's happening and having somebody else take care of it, that would be my advice, is to be a little bit more involved. And
Great
that way
advice.
they have a control, right? So the idea is they can control more that way if they know what's going on, good or bad. And that way they have more control over their practice.